الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم الصراط الذين أنعمت عليهم ولا الضالين. There should be 144 of you, right?
Yes, Mr. But we just finished our session with Mr. Yusof, so they might on their way to join this session. Sorry, Mr.
Okay. Righty-ho. Can you see my slide? Is it moving?
Yes, moving.
Okay, fine. Okay, today I've been given the task to talk about pancreatic cancer. So inshallah, I'll try to cover as much as possible the important things that you need to know at the level of undergraduate. Just before I start, I'm not sure whether Mr. Yusof reiterated some points before he started this morning. Did he mention about what are the things that you need to cover in surgical posting? Did he mention anything?
Just now,
No, Mister.
All right. Basically, everything that is inside your logbook can be asked in the exam. That includes the practical procedures, because I find that students tend to neglect the practical procedure sites. Understandable that you cannot perform them, but as I given the during the briefing, I mentioned that you are able to go and organize whereby you can assist, you can observe those procedures being performed. And I'm not just saying to you guys, to year 3 also the same, previous batch also the same. People tend to neglect. So we have decided we're going to ask those things in the exam. So like it or not, if you neglect those aspects in the exam, you're going to have problems answering the questions. So look at the logbook. There are practical procedures there. Go and find a way where you can learn how to perform them. Even though you cannot perform, you can learn the steps, learn how to prepare. Okay? Because sometimes it's difficult to you know, to make sure that you guys do. This is not undergrad. This is not sekolah rendah, sekolah menengah anymore. You need to get those done, and we as the teachers, we have to do something. So now we're telling you, it might come up in the exam. We might ask those questions. If you decide to ignore it, at your own peril. Okay. Okay, let's carry on with the lecture on pancreatic cancer. I'm sure you have come across this during the 3rd year, and I'm sure you have come across numerous discussion and numerous patients in the past about pancreatic cancer. But nevertheless, it's something that needs to be emphasized upon because of certain points that I'm going to bring up. So this is what we're going to cover in our topic today. A bit of introduction, incidence, prevalence, the type of cancer, presentation, Courvoisier law, risk factors, location, diagnosis and staging, treatment, and last but not least, pancreatic neuroendocrine tumor. On the right side, you can see the anatomy of the pancreas itself. If you see, most anterior is the stomach, and then behind the stomach in the lesser sac, you will see the pancreas. And as you can see, the pancreas margin and around the head of the pancreas, it is very close proximity to the duodenum. And also, as you can see, the bile duct combines with the pancreatic duct. It opens up into the duodenum at the ampulla of Vater. Immediately behind the pancreas, you see the presence of portal vein. And as you know, portal vein is the confluence or the combination of the mesenteric or the superior mesenteric vein and also the splenic vein. They come together and become portal vein. And behind the pancreas as well, basically being sandwiched between the neck and also the uncinate process is where superior mesenteric vein and also the superior mesenteric artery. And then in close proximity to the pancreas, above it is the celiac trunk and the common hepatic artery. And behind, obviously, is the aorta. Okay, so those are the relation of pancreas that will come into play, come into context when we decide for treatment of our pancreatic tumor. So a bit of introduction into the importance of knowing pancreatic cancer. It is the 11th cancer in terms of incidence worldwide, and is the 7th cause of death worldwide. And the overall survival rate is about 7.2% at 5 years. In Malaysia, the age group affected usually above 45 years old, and usually it peaks in the sixth decade of life. And it has a more male preponderance compared to female. And in papers that's been published in the past, it tends to have a higher incident rate in Chinese population. And the median survival rate from diagnosis in our country is usually around 3 to 4 months. And the reason being is that they tend to present late. Okay, here is the table. This is not Malaysia. This is worldwide. Okay, this is worldwide median survival in terms of months from the point of diagnosis at various stages of presentation. Obviously, this is a median. Like I said just now, for our median survival 3.4 months. But that is because most of our patient presents already at the stage 4. All right, and beyond resectability or beyond curative. 90% of cancer, of pancreatic cancer, are adenocarcinoma of the ductal epithelium. Less than 5% actually are made of pancreatic neuroendocrine tumor, which includes tumor like gastrinoma, insulinoma, and glucagonoma, to name a few. There are others. Basically, they are named according to the hormone being secreted by those tumors. Okay. There are also other benign precancerous lesion, cystic lesion of the pancreas, so to call as a group, cystic adenomas, mucinous adenoma, and these are the one that you need to be aware is what's called intraductal papillary mucinous neoplasm, because this particular tumor, although it is still in its benign phase, it has a high, it is called a pre-malignant lesion, similar to our Barrett's esophagus. So Barrett's esophagus is actually non-malignant, but it is pre-malignant, whereby if you leave it behind, leave it on its own, it can turn malignant. Similar with IPMN. Okay. Um, for the remainder of the talk, I'm going to focus on adenocarcinoma on itself, and at the end, I will give a little bit on the pancreatic neuroendocrine tumor as well. Okay, because most of the time you're going to be dealing with adenocarcinoma, right? So in terms of presentation, and this is important, this is the most important slide for you to remember. Most cancer in the pancreatic region present late. It is because they are located at an area in the retroperitoneal region whereby a mass will not be detected early on. And the other thing is because their location, they don't tend to cause any presentation, as they do not impinge on anything during the development of the mass until they have developed sizable volume, sizable sizable effect to cause compression, which may present with pain, or they can cause obstruction to stomach, which may present with loss of appetite or early satiety even sometimes. Only then they actually present and you examine the abdomen, yes, they have a mass there. Even our patient sometimes in terms of education, patient choose to ignore those signs. They may have noticed, there is a mass growing there, slowly growing, but they thought, oh, maybe it's angin. And that's one of the problem in our system, whereby patient goes to multiple health centers, or not health centers lah, I would say GP, KK. Sometimes it did not trigger for people to investigate further. And most of the time being treated as gastritis, gastric, or angin lah. But the thing is, not only the abdominal pain would be the defining character. Okay, sometimes they just have a dull ache, dull persistent ache, And sometimes they can also have a dull ache in the upper abdomen which radiates to the back. And most of the time people just say, ini lenguh-lenguh badan buat kerja banyak. And unfortunately, that has been persistent for many months, and by the time it has grown, it is too late. It has already involved other organs. It have probably metastasized at that point. So dull upper abdominal pain, back pain, with or without jaundice, okay? Because jaundice is another important features that you need to pay attention, especially if it is painless jaundice. Can I ask anybody know what does painless jaundice mean actually?
Your patient have macam taste of jaundice, but there doesn't have any right iliac fossa pain or something like that.
Right iliac fossa.
Eh, eh, right apa?
Okay. So what does that mean? What does that tell you? What is the conclusion you can make from that statement? Patient has painless jaundice. What diagnosis comes to mind?
Hemolysis.
One I've given there, head of pancreas tumor. Anything else?
Periampullary carcinoma,
Periampullary carcinoma, which are
cancer the duodenum, ampulla of Vater, common bile duct,
which part of the common bile duct?
the distal part.
Distal common bile duct. Yeah. So
Yes.
there's four of them. So painless jaundice. One, if you're thinking of malignancy, these are the four that you need to think about. Secondly, it can also be metastatic. So bleeding basically is because metastasis in the liver. It can come from any source. Thirdly, it can also be hepatitis, drug induced, right? So don't confine yourself to only malignancy. But what I want you to think, or to the way you think, is okay, I have malignant causes I need to rule out. I have benign causes that I need to rule out. The malignant causes can be primary, which are the periampullary tumor, or it can be secondary from any tumor anywhere else. And also the metastatic cause, and also the medical causes. All right. Next is the unintentional weight loss. So patient having upper abdominal pain and then unexplained weight loss. When you examine the patient, you don't feel any mass. But patients say they eat, they cannot, they don't get anything. And then even sometimes they actually complain of having diarrhea, as if patient is developing endocrine insufficiency. Endocrine pula. Exocrine insufficiency. As if they have they don't have lipase, and they develop steatoria sometimes. Okay. Then you also need to be aware or be a bit wary when the patient said they suddenly develop new onset diabetes out of the blue. Okay, patient is obese and all that, but not just new onset diabetes lah. It has to be coupled with other symptoms as well. So that would be a sort of a telltale sign that something is going on with the pancreas. On physical examination, you may find a mass if it's already grown to significant size. Some patients memang present that way, whereby they decided to come to the hospital when they find that there is a huge mass, or they think the mass has not grown any smaller. You might find palpable gallbladder. Whether it's painful or painless is another matter, but in this case, we're thinking of a painless palpable gallbladder. Patient might present with ascites, but most of the time it is unremarkable. Apart from patient might be slightly cachexic or showing signs of malnutrition. You don't find any mass, you don't find anything wrong apart from patient say I'm losing weight, that's all. So that's why I want you to remember from now on, any patient having unexplained abdominal pain, not typical of your peptic ulcer pain, not typical of your dyspepsia, just a dull ache, bloated, think of investigating this patient. So what are the investigation you think you might suggest? I would say first you can do OGDS, because obviously epigastric pain. We were thinking peptic ulcer, just do OGDS. That's very simple, very quick. 10 minutes, you already got your diagnosis if it's peptic ulcer or if there's anything else. And if it's unremarkable, then proceed to the next level, which is ultrasound. By performing ultrasound, you don't lose anything. You can actually catch the disease early on, at least not while it is still small. Perhaps it is easier for us to think of maybe curative resection. Okay, so this is just a bit of revision. I'm sure you have heard us asking you about Courvoisier law. Okay, now I'm just going to tell you again. So Courvoisier law states painless jaundice in the presence of a palpable gallbladder, the cause of the jaundice is unlikely to be due to stone. Anybody care to explain to me why this statement comes about? Why is it not due to stone? No?
Because if it's due to stone, the gallbladder will undergo repeated inflammation and will finally cause fibrosis. So when the gallbladder is fibrous, it will become unpalpable.
Yeah, correct. So stone likely has had multiple attacks of inflammation, which leads to fibrosis. Thus, it won't be able to expand that much to the point that it is that much palpable. Yes, you are right. But the caveat here, there is a caveat whereby a double stone may actually present similarly. The patient might have a stone in the gallbladder and might have a stone in the common bile duct. Will also present with a jaundice, but stone itself, if it causes obstruction in the common bile duct or even stone inside the gallbladder, would normally give pain. On a rare occasion, it might just be without pain. But anyway, when you find that palpable gallbladder, jaundice, you have to think a little bit further. Do not just take it face value that this is a simple benign case. Okay. So risk factors for pancreatic cancer. Obviously, smoking contains carcinogens. Obesity has been implicated in so many cancers nowadays. Any GI, breast, endocrine, all those are implicated in obesity. Therefore, obesity is something that we need to avoid and try to combat quite religiously. Okay, primarily because the theory is that obesity is a state of inflammation. When you have inflammation, persistent, recurrent inflammation, sometimes there might be cytokines, there might be mutation going on, and that can lead to cancer formation. Chronic pancreatitis is another, whereby patient who are undergoing process of chronic pancreatitis, they develop fibrosis, repeated attacks, scarring, inflammation. With those attacks, every time inflammation occurs, there are changes occurring in this tissue. And during those changes, the mutation may occur, which then leads to formation of cancer formation. Okay. Diabetes, just now I said diabetes might be a sign that patient is developing cancer, but having diabetes in the first place has been associated, 10% of diabetic patient has been associated with formation of cancer, although it is not a direct correlation, okay? But it's not a direct causative event. No, not necessarily having diabetes causes patient to have pancreatic cancer, but it is implicated as being risk factor, that possibly there is a link. Okay, family history also implicated as being a risk factor. Certain genetic mutation, BRCA2, KRAS2, P53, and CDKN2 has been shown to be risk factors which may lead to pancreatic cancer. IPMN, as I mentioned above, has been the pre-cancerous or pre-malignant stage of benign before eventually turning into cancer, similar like Barrett's esophagus. This pancreatic cancer can also be part of the MEN1, multiple endocrine neoplasia 1 syndrome, right? And usually this one is not adenocarcinoma, it is the neuroendocrine type. And chemicals from dry cleaning and metal work has also been implicated as a risk factor. Now, location of the pancreatic cancer, 60 to 70% of them are located at the head of pancreas. About 20 to 25% are located at the body and tail. The rest are in the neck, in the uncinate process and all that. Now, with head of pancreas cancer, they, as I said, in general, most pancreatic cancer presents late because of their location, because of the way they are. They don't actually cause any effect to any other organs. Therefore, you don't find any symptoms. But with head of pancreas, because of the presence of common bile duct that travels through the head of the pancreas before it goes into the ampulla, patient may present with jaundice due to the obstruction. All right, and but by the time they get jaundice, usually it's already a sign that the tumor has grown to a significant size that it may be a higher stage, not just a stage 1 or stage 2. Right, so that in itself carries not a very what you call, it's not a very comforting prognosis in a sense, because overall pancreatic cancer is very aggressive. Okay, adenocarcinoma of the pancreas is very aggressive. The problem with the body and tail tumor, again, because there's nothing much in the close proximity to that area apart from the stomach. So a small tumor might not present or give any symptom whatsoever until it has gone or has grown to a significant of size that it causes mass effect, usually to the stomach. That it push the stomach forward and causes the patient to feel full because, or basically early satiety, and then or even discomfort. But then by that time, the tumor is big enough for you to even feel it. Right. So that's why pancreatic cancer is very difficult to detect at an early stage. Okay. Here's an example of a pancreatic tumor in the region of the head. If you can see the CT scan on the left there, the hypodense, irregular looking lesion, yeah, with marked with the arrow, and on the right is the schematic drawing. Okay, so what is not depicted here because it's only a one slice is that what happens to the proximal. So the picture here is showing dilatation. All right, dilatation of the CBD and also the common hepatic ducts in upwards. Here it doesn't show that the pancreatic duct is dilated, and even on the CT scan you don't see it. But one of the classical signs to suggest head of pancreas tumor is what we call double duct sign on imaging. So here is what I'm trying to show you, the double duct sign. On ERCP, when we cannulate, you can see here, you don't see anything at all. See, the scope is here, and they have put in two guide wire, one guide wire into the pancreatic duct. Pancreatic duct is very small normally, 3 millimeters saja, and this is definitely more than 3 millimeters. And then the other duct is going up into the bile duct. And as you can see, you don't see anything at all between the end of the scope and this two junction here. And on the MRI, you can see there is that mass here, which is sort of almost abruptly tapering the common bile duct, and almost like maybe obliterating completely the pancreatic duct alone. And on CT scan, you can see that there, pancreatic duct, you can see the pancreatic duct, you can see the common bile duct, and that's the gallbladder, but there is a mass in between. Okay, so double duct sign is a feature of tumor at the head of pancreas. So when you read ultrasound or when you read the report of CT scan, look out for the double duct sign, meaning that dilated pancreatic duct and dilated common bile duct, and then you know the tumor is at the head of pancreas. This is an example of tumor at the tail of the pancreas. Okay, as I mentioned earlier, there is nothing in front of the body and the tail apart from the stomach. So see, even with this big mass, the stomach can still expand normally. So this patient might still be asymptomatic, might not feel anything at all in terms of the finding. Apart from patient might complain that he's losing weight or he might complain that he's having diarrhea, perhaps. So that's why it's very difficult for us to detect pancreatic cancer at an early stage. Usually by luck, by chance, patient may undergo imaging for other reason and found to have this lesion. Only then you can get it early. Okay. So in terms of diagnosis and staging, how do we diagnose? Obviously, the main one is I iterated at the beginning during the presentation is the history and the physical finding. Even that, it is very, very unspecific, non-specific, especially when there is no jaundice. Like the tail of pancreas, there won't be any jaundice. Like I said, patient can just say some abdominal dull ache, a bit of weight loss. If you do not take it serious, if you assume, jangan assume. That's the thing. Another lesson: do not assume. If you assume this is something simple, something not very serious. I mean, non-malignant. That might lead to patient coming again and again to multiple practitioners and ended up delay in their investigation. Okay. Deranged LFTs on the blood image investigation, that would be for the ones that already presented with jaundice, then you will find that. But if it's in the tail of pancreas, you might not find anything, especially if there is no metastasis or sizable metastasis yet. Small metastasis usually is asymptomatic. Tumor markers CA99 and CEA are the ones that you can use. The thing is, CA99 can also be raised in multiple other cancers, similarly with CA. So they are sensitive, but they are not specific, okay, to particular condition. But they can be useful in terms of managing, or you can be useful in terms of monitoring or surveillance or response to follow up, response to treatment. So you can use that if they are raised in the first place. If the tumor is not secreting any of the tumor markers, then you can't use them. In terms of diagnosis, imaging, as I mentioned, ultrasound is the first protocol because it's easy to obtain, but it won't be able to give you much information. Sometimes if it's small, it cannot pick it up. So the best modality and commonly or widely available is contrasted CT. Pancreatic protocol basically refers to the way they take the image of the CT scan, whereby they would give specific attention to the region of the pancreas, and they would create or reconstruct very thin slices in order to see the lesion. One radiological consultant once told me, for just a pancreatic tumor, which is sizable enough to be seen on ultrasound, and you think it's going to be adenocarcinoma, contrasted CT abdominal is enough. No need to do pancreatic protocol. But for neuroendocrine tumor, because they tend to be very small, it is recommended to do pancreatic protocol. However, for us surgeons, we still want pancreatic protocol because we would like to actually see the relationship of the tumor to all the vessels and structures surrounding, so that we may plan our surgery better. MRI, it is helpful, but very difficult to obtain. Therefore, usually CT pancreatic protocol is sufficient. PET scan, usually not very helpful in terms of the primary tumor itself, but it is good in terms of managing or trying to stage for distal metastasis. Right? Endoscopic ultrasound is useful, especially in detecting small tumors. Okay, whereby you can actually use endoscopic ultrasound to also assess the relation of the tumor to surrounding structures. And I put down here biopsy. Do we need biopsy for confirmation of tissue for pancreatic cancer? Can somebody answer? I put down the question biopsy. Like breast, thyroid, kita kena buat FNAC at least Colorectal pun kita kena buat colono and biopsy. Gastric pun sama. So, do we need biopsy for confirmatory diagnosis?
Maybe yes, we need biopsy.
Okay, you want to do biopsy from how do you going to do biopsy?
Maybe we can do biopsy under endoscopic ultrasound.
Endoscopic ultrasound. Would you do percutaneous? Minta Prof. Razali tolong buatkan. Say for example, you work in HTA, tak ada US. You ada, tapi you ada interventional radiologist.
It might perforate inside the abdomen.
Perforate? US? Okay, US. Okay, that is a risk factor. But usually we would do it gently lah. But anyway, any other reason? Okay, the answer is for pancreatic protocol, for pancreatic cancer, for liver cancer, even renal cancer, usually we don't do biopsy. Okay, solid cancer like this, we don't do biopsy because but we can only we can do biopsy for pancreatic cancer if we perform endoscopic ultrasound through the duodenum. Okay, because why? If you do percutaneous, the tract that you use to puncture would be, there will be tumor seedling along the tract that you have punctured percutaneous. That's number one. Number two, by puncturing the tumor, you now created a tumor which is confined to within the organ to a perforated tumor. It doesn't mean that it's perforated. It's just that the tumor now from T1, T2, T3 has become a T4 tumor. Do you get my point? Usually T3, T1, T2 are basically tumor which is still confined to the original organ. It hasn't spread outwards. T4 means it has gone beyond the borders of the primary organ and now has been spread to other areas. So you have converting something which is potentially curable to T4 which might not be curable because you have spread, or maybe you have to do a more extensive dissection. So for cancer of liver, cancer of pancreas, we don't do biopsy, percutaneous. But if you want to attempt, you can attempt endoscopic biopsy. Because why? Endoscopic ultrasound through the duodenum is going to be the area that we're going to resect anyway. So spillage into the duodenum itself is okay because we're gonna resect itself, and then it's a contained spillage because it's in the duodenum. If it's spread into the peritoneum, difficult for you to control because it's spread all over the place. Okay. But the time that when we actually do biopsy, definitely we'll do even percutaneously, is when the tumor has spread, meaning that the tumor is now already metastasized. So if you see on the CT scan, patient has got lung metastasis, liver metastasis, okay lah. We just do biopsy to confirm the diagnosis, then we give palliative chemoradiology. Because to give chemo, you need tissue. If you are going to resect, no need to biopsy, you just resect. And then you see the biopsy, after that you can give chemo. So you already, the resection itself is your biopsy lah. Because you do not want to delay. You take biopsy, it takes another 2-3 weeks for you to get the result, or another delay kan. What if the biopsy even negative? You don't delay already. So usually if the tumor is resectable, we don't biopsy, we just straight away resect. Now here are some causes of elevated CA19.9. So they are benign and malignant causes. So be aware guys, yeah. In cholelithiasis, you have obstructive jaundice secondary to stone, even in cholangitis, even cirrhosis, you can get elevation of CA19 sometimes into thousands. We have seen patients coming with CA19 of about 1,000, 2,000. And then we remove the obstruction, we put a stent, within 1 month, that 1,000 dropped down to about 300, and then even lower and lower and lower. So it does not mean they are in the thousands, they are cancerous, but you have to take it in the context of the patient's presentation. If the presentation is only looking like a benign condition, there is no weight loss, only obstructive jaundice, there is no other mass there. You do ultrasound also did not show any mass in the pancreas. Chances are this is a benign condition. But if patient already coming to you with jaundice, but then also palpable gallbladder and then weight loss, when you do ultrasound, there is suspicious looking lesion in the pancreas, maybe presence of lymph nodes. So you might want to think maybe this is malignant. And for malignant causes, not only pancreas, it can also be related to hepatocellular carcinoma, or even cholangiocarcinoma, even gallbladder carcinoma. All right, so it's not specific to any particular cancer, but it is something that can be useful for surveillance. It can also be implicated in gastric, ovarian, colorectal to a lesser degree, even rarer for lung, breast, and uterus. It can still be raised, but less, right? And similarly, I didn't do one for CEA because CEA ni can come anywhere along the GI tract. Any cancer along GI tract is even implicated in breast, even implicated in many things. So, but most commonly in colorectal lah. Again, it's not specific enough, but it is useful for monitoring of treatment if it was raised in the first place. If it's not raised, you can't use it because this tumor is not secreting that particular tumor marker. For staging, on the right side is the basically explanation. On the left side is the pictorial description of what we have on the right side. So we use the 8th edition, the newest one, whereby T1 is anything less than 2 cm and divided further T1 into 1A, 1B, and 1C. So less than 0.5, 0.5 to 1, and 1 to 2 centimeter. T2 is 2 to 4, and T3 is more than 4 cm. And when T4 now is involved other surrounding organ regardless of size, and lymph nodes as well, and metastasis lah. You know whether you have metastasis or not. All right. Now we come to treatment of pancreatic cancer. So obviously we have curative intent and palliative intent. For curative intent, surgical resection offers the best outcome. That's the only one that can give you curative resection, outcome, right? This is coupled with adjuvant chemo and radiotherapy. And some patients, neoadjuvant chemoradiotherapy may be administered prior to surgery. Okay. For palliative, there are a few things that we need to consider. Number one is patient presents with jaundice. So you need to do something about the jaundice, whereby you need either you can put plastic stent or you can put metallic stent. In some cases, the tumor grows so big that it actually causes difficulty for ERCP to actually stent. Maybe it's completely blocked. Our guide wire cannot get through at all. So you have, or even sometimes the tumor is so big that it actually compresses the duodenum or distorts the duodenum that we cannot get our scope in position. So the endoscopic ultrasound has been tweaked and modified, whereby it can be used as a modality for us to put in drainage or stenting. I will show the picture later. If unable to do so, unable to perform all these things via endoscopically, there are also surgical bypass that we can implement using what we call a triple bypass. I will show it later. Next, patient will have problem with pain because pain in pancreatic cancer is a multimodal approach because it's actually multifactorial. It's not just the tumor because the location of the pancreas at the back usually is very close towards the celiac plexus. Sometimes it presses on the nerves at the back, even local infiltration. Sometimes due to the tumor obstructing the pancreatic duct causes edema of the tumor, peritumoral edema, or stretching of the capsule that causes pain. So doing a celiac plexus blockage can also prevent those nerve impulse from reaching the brain, so that basically you trick the body into saying, oh, there is no pain. Okay. And sometimes we can give radiotherapy, which is directed towards the celiac plexus to give relief of pain. And don't forget, these patients also requires nutrition. So you need to find a way to feed the patient. If the tumor has obstructed the duodenum, that means patient develop gastric outlet obstruction, you may want to decide on doing a bypass anyway, because then you need, or maybe you might think of feeding jejunostomy. Okay. Now let's talk about the curative intention. So first thing that you need to discuss upon are these two keywords: resectability and operability. Operability is a fitness of the patient to undergo major surgery. So if the patient has so many comorbids, or patient not well, having a lot of sepsis, shock, you need to optimize the patient. Okay. Sometimes the comorbid so bad, ischemic heart disease, very bad lung disease, memang cannot survive major surgery. Therefore, patient is not fit for surgery. That's number one. So if patient fit, then okay, thank. Now, secondly is resectability, meaning that the tumor itself is whether the tumor itself is resectable or not based on its features on the scan, whether it has invaded to surrounding structures. Basically, your aim is to provide curative treatment. For curative treatment to be achievable, the tumor must be able to be removed entirely and then without any with a R0 margin. R0 means no tumor macroscopic or even microscopic left behind. So for that, you must have good clear margin with all the surrounding structures. So that's resectable. So resectable tumor means there is no metastasis, number one. So if there's metastasis, forget it. It's no longer resectable. You're not gonna put a patient through a major surgery like that for a tumor which has already metastasized, because the morbidity related to the surgery itself might not be worth trying, because then the patient might not have much time left pun. As I mentioned earlier, the median survival is very, very short, especially when it's already stage 4. All right. So might as well do something which will keep the patient comfortable, give a quality of life, rather than going for major surgery, which will keep the patient in the ward for a long time. So vascular involvement is important for us to assess. Number one, superior mesenteric artery. As I mentioned earlier, when I talk about the anatomy, all these are important vessels that if any of them are involved, will require for us to think twice about whether this patient is resectable or not. Okay. But if none of them are involved, even there is no invasion to the duodenum tu tak ada masalah, because it is what we know the duodenum is in close proximity anyway, we're going to take it out, no problem. But say invasion to the liver, that means direct invasion to the liver, this is already metastasis, not resectable. Okay. Borderline. Now this is a special category. All right, borderline. Previously, the moment you say the tumor touches a vessel, it's no longer resectable. But as the technology, as the understanding of tumor, the development of chemo agent, radiotherapy improves, these categories are now being redefined. These are the category of borderline resectable, whereby tumor abutment to vascular structure and abutment of less than 180 degrees. Sorry, abutment is basically the tumor has close proximity to a vascular structure, but the circumferential involvement is less than 180 degrees. And encasement is when the tumor has gone beyond 180 degrees. So anything less than 180 degrees is considered tumor abutment. Therefore, it is termed as borderline resectable. And for borderline resectable, that means at this point in time, it is not resectable. But we're going to try and give neoadjuvant therapy. Sorry, not neoadjuvant. Sorry, there's a typo there. Neoadjuvant therapy. And then we're going to reassess balik. We're going to rescan. If after neoadjuvant therapy, the tumor has shrunk, and then now the abutment is even lesser than 180 degrees, or even now there is a clear plane with the vessel, then this is resectable. because if the tumor is actually at the 180 degrees or even touching the vessel, we cannot resect. We cannot cut those vessels just now because those are important vessels. You cannot cut them. The only vessel that is available, that is possible to cut, is portal vein, and that is only at the portion above the confluence, whereby we can involve the vascular surgeon to come and reconstruct that that length of portal vein. But anything near the confluence, whereby the joining of splenic vein and superior mesenteric vein, you cannot reconstruct. So therefore, you cannot resect the tumor. Right. So this is a new limelight. This is a new hope for those who are borderline resectable, that we can actually give new adjuvant and see the response. If the response is favorable, the patient will now be upgraded to resectable tumor. Okay. So the unresectable is basically everything else lah. Either it's metastasized or encasement of those vessels. That's it. No more resectable. Even the borderline, if you give new adjuvant, no response, it remains unresectable. So it becomes unresectable. Yeah. So for curative intent, if patient is operable, patient is resectable, the treatment would be Whipple procedure. So for Whipple procedure, we will remove distal gastrectomy at the antrum. We will remove the gallbladder. We will then cut the bile duct at the common hepatic here. We will remove the head of pancreas, and we will remove a small portion of the duodenum, usually at the D2 lah, beyond the D2, because that's the C segment. And then from this stump, we will reconstruct. You will have 3, sometimes 4 anastomosis. So the first anastomosis is here, pancreatico-jejunostomy. Secondly is the hepatico-jejunostomy. So the common hepatic duct to the jejunum. Then this is the gastro-jejunostomy. Sometimes we might even do one more here, what we call jejuno-jejunostomy. That is just to allow for food. Say for example, the food goes this way. This is the way that you want the food to go lah, along with the gastric juice, along with the pancreatic and the biliary bile, with the bile. But if you can see, this loop sometimes become what we call a redundant loop, and then it will be stagnant there. If food comes here, it might stay there and doesn't actually go down further. So what we do another anastomosis here, what we call jejunostomy. So whatever comes here will go down, and even if it comes down here, also will go down. So that will ensure that the food goes straight downwards. There is no what we call afferent loop syndrome, whereby they become stagnant. This is the problem with this technique, is that there is this very fast movement of food bolus from the stomach, because we no longer have the pylorus to control the movement of food into the duodenum or into the jejunum. So the amount of food that goes straight into the small bowel when it's too fast may lead to dumping syndrome. Okay. So to avoid that, there's another technique called pylorus preserving pancreatico-duodenectomy. So what it is the stomach is not cut at the antrum. Instead, it is transected at the D1. Okay. But the other steps are similar. Okay. The other steps are similar. They transect at the common hepatic, D1, pancreas, and also the jejunum, the duodenum, the distal duodenum. And then reconstruct in the same manner, but then the D1 is now reanastomosed to the jejunum. Okay, so this is a bit more what we call the physiological. Now you see the pancreas, there is no redundant loop straight away. So straight away they will then mix and come down, right? And with the presence of the pylorus, the amount of food that being released into the duodenum also be minimal or slowed down. So this avoids the dumping effect. So this is another technique that is preferable in terms of avoiding dumping, but doesn't mean one is superior to the other in any sense. It depends on the preference of the surgeon and also the condition of the tumor. How big is the tumor? If the tumor is so big, involving even this portion of the stomach, you have to cut here. So it depends on that as well. All right. Uh, okay. Now I'm going to show you the triple bypass. So, like here, the tumor is here. So when the tumor is unresectable for whatever reason that we discussed previously, we can't actually allow that. Sometimes the tumor is so big that it's actually blocking even this part. It causes luminal narrowing. So patient not only have biliary obstruction due to the head of pancreas tumor, but they may also develop gastric outlet obstruction. So to avoid that, what we do is we cut at the duodenum or jejunum, sorry, and bring the proximal jejunum and anastomose to the common hepatic duct. You have two options actually. One, you can actually anastomose to the common hepatic duct. Another technique is actually we anastomose to the gallbladder. We can even anastomose to the gallbladder. So now whatever is obstructed will come up through the gallbladder into the small bowel and down here. And then we have another anastomosis here at the stomach with a gastrojejunostomy and jejunojejunostomy. So triple, 1, 2, and 3. And then you're going to ask me about how about the pancreatic duct? I mean, we can't do anything about that. If the tumor has blocked completely distally, the pancreatic duct and the bile duct, there's nothing you can do about the pancreatic enzyme. But what we can do is we can modify the patient's diet. We can give them semi-elemental, meaning that partially digested diet. The special milk, the peptamen, especially they don't taste very well lah. They don't taste very good, but they are partially digested, so easily for them to absorb. But you know, this patient quite advanced, their life expectancy actually is not that long anyway. But this is to actually help them so that they can actually go home without cholangitis, without jaundice, and can have a quality of life. So that's the aim of this triple bypass. But this is only offered if the patient during presentation is already advanced, but they are actually quite well enough to undergo surgery. They have still good reserve. They actually are the ones that you think might do good in terms of improving their lifestyle, their life quality of life after surgery. Then you can go for this lah. So metallic stenting, this is the one that I mentioned earlier about putting a stent. So as you can see here, see there's a long gap between the end of the scope and also the end of this the duct. But the duct should go all the way down here, but the tumor is there. So if you can see here, they have placed the stent, and you see this segment is narrowed because this is where the tumor is actually compressing. You can perform this procedure if you are able to cannulate the ampulla, pass the guide wire up. Yes, you can perform stenting through ERCP, and that's what we have performed numerous times. We normally put in a metallic stent uncovered. Why uncovered? Because the uncovered allows for the tumor to actually hold the the metallic stent. And you ask me, is it going to well, it can grow in and cause obstruction. Yes, it can grow in, cause obstruction. And sometimes what we need to do, we even put a plastic within a metallic stent. And as you know, you put a metallic stent to give them at least 3 months of worry-free lah, because the life expectancy also is not that great, 3-4 months only. So at least in the 3 months, so they don't have to worry about changing stent. They can go about their daily life. Some patients have a very slow growing tumor, whereby we have to change the metallic stent, the plastic stent within the metallic stent a few times. Eventually they succumb lah. But the idea is to actually give them something which is permanent, which will keep the lumen open and allow them not to be coming in and out of hospital too much, so they'll be at home with their family. This is the EUS guided biliary drainage. Okay, so this is the traditional way. We use a ERCP scope. We try to get in here, but sometimes the tumor is so big or the tumor has completely blocked the CBD that you can't get at all. So one way we can do is using the endoscopic ultrasound through the stomach. We can actually get into the common bile duct here. We can puncture through the stomach and then get into the common bile duct and can put what you call the stent, plastic or even a metallic stent this way. Another approach is we can puncture through the stomach as well and goes into the left intrahepatic duct, which is what we can see here. See, the white line is basically representing the stent which has been punctured from the stomach straightly into the left hepatic duct. Right now, because it's already being drained, you don't see the dilated duct lah. But you can see the right side still dilated. And this ring here, this patient may have had another stent placed previously, right? That's another approach is sometimes that we cannot get from bottom. We pass a wire from the hepatic duct into the bile duct, and then we can then go down and use that wire as a guide for us to get into the bile duct and place a stent down here. So this is US assisted, or it's either you do direct drainage like this one, you directly drain, or you can use that to put a guide wire and use that as a guide for you to get into the bile duct from below. Okay. In our center in Sasemek, nobody does this, but UM and Selayang has got this service, but done by the gastroenterologist. I mentioned earlier about celiac plexus neurolysis. Okay, celiac plexus basically areas of ganglion that is very close proximity to the pancreas itself. This modality has been used not only for pancreatic cancer but also for chronic pain secondary to chronic pancreatitis. Right. So the anesthetist normally they puncture percutaneously lah. But for us, because we have US, we can actually use US and puncture. There are multiple ways to actually do the neurolysis. One is we can use the local anesthetic. Usually for NS, they use local anesthetic lah, but that is only short-lived, limited, and then it will go away. But for us, we will use agent that actually kills the cells in that region. Where normally we use alcohol lah, ethanol injection, or you can use RFA, radio frequency ablation, to burn the celiac ganglion. So that will prevent patient from having pain. Another modality is to give radiotherapy to the region, and so that will also give pain relief, right? So that is in a nutshell about about adenocarcinoma of the pancreas. Any question? No? Can I proceed to pancreatic neuroendocrine tumor? Hello?
Boleh tu.
Boleh? Okay. So pancreatic neuroendocrine tumor, basically they are islet cells tumor. Okay, these are the endocrine cells within the pancreas, and they are very uncommon. Even although pancreatic cancer is already uncommon, this is even more uncommon. This is 1 to 2% of all pancreatic neoplasm, but it has a better prognosis than adenocarcinoma. It is divided into either functional or non-functional tumor, for which 20% of them are non-functional. They are usually localized disease. They don't metastasize that much or that early, and they are associated with MEN1 syndrome. So there are different types of pancreatic neuroendocrine tumor. It is divided based on the functioning or the active hormone that they secrete. Most common pancreatic neuroendocrine tumor is insulinoma, followed by gastrinoma, and then the non-functioning type. There are others like glucagonoma, somatostatinoma, vipoma. Okay, and they are being secreted by different type of cell which is present in the pancreas. Okay, as I've listed down here: beta cell, alpha cell, delta cell, D2 cell, G cells, and so on. There are others lah, but these are the common ones. So for insulinoma, this is the most common type. 10% of insulinoma are malignant. So only the other 90% mainly benign. And they usually are very small. That's why when I mentioned earlier, in the CT scan, we might need to use pancreatic protocol so that the radiologist will reconstruct the image with a thinner slice at the pancreatic region for us to catch this insulinoma type, very small tumors. So pancreatic neuroendocrine tumor is usually very small. They don't grow that big to cause symptoms because they can cause symptoms while they are still very, very, very tiny. Special thing about insulinoma is that they present with this neuroglycopenic symptoms. So why neuroglycopenic? Because they also have, not only they have glycosemic symptoms, but they also have that effect to the neurological symptoms system, in a sense that they have dizziness and headache, but also amnesia. Okay, there have been cases where patient actually cannot find their way home, right? They don't know, they forgot that they haven't gone home because they might go to sleep and thought, oh, okay, that's okay, now I already, I'm at work, continue working. And for insulinoma, there is this Whipple's triad that is being the correct criteria of diagnosis, whereby patient will present with low glucose level, and they also would demonstrate hypoglycemic symptoms, and the symptom will resolve with administration of glucose. All right, so that would suggest presence of insulinoma. Okay. Next, most common is gastrinoma, and this is associated with what we call Zollinger-Ellison syndrome, whereby presence of multiple peptic ulcer, which causes upper abdominal pain and upper GI bleed. And 60% of carcinoma are associated with being malignant, and the location of the tumor itself are described as being in the Passaro triangle. So Passaro triangle borders by these points here: CJAP and CBD, D2 D3 junction, pancreatic neck and body junction. So you will find the tumor in this region. Okay. Now, if the tumor is located somewhere near the stomach, you might need to do a gastrectomy lah, not just a Whipple lah. So it depends on where the location of the tumor. Right. Next is glucagonoma. This is very rare. It's more common in female, and most common, as you know, glucagon itself is to release everything, to break down everything, to release sugar and to release energy. So most patient present with malnutrition, catabolic effect, where they cannot keep anything. They don't keep anything, and 50 to 80% of them are malignant. The special thing about glucagonoma is they have this specific dermatitis, what we call migratory necrolytic dermatitis, as a result of severe amino acid deficiency. They may form bullae, and sometimes they have superimposed bacterial fungal infection. Because they are rare, I myself also have not seen this, only in textbooks. Okay, maybe the neuroendocrine, maybe the endocrinologist, or maybe the breast endocrine surgeon might have seen something like this lah, or even the hepatobiliary surgeon might have seen something like this. Vipoma, vasoactive intestinal peptide oma. Again, another rare tumor. It presents in a bimodal age distribution, so very young or middle age. In the between tak ada. 2/3 of them are malignant. So as the mention suggests, vasoactive intestinal peptide, so they tend to develop GI secretory symptoms, so watery diarrhea, flushing. So due to the secretory, quite a lot of secretion, they develop achlorhydria and hypokalemia. Okay. So for diagnosis of pancreatic neuroendocrine tumor, it is all based on the history which is suggests of endocrine symptoms. So basically from the symptoms that were mentioned earlier, and then you perform the hormone level. So it depends on what hormone you're looking for lah. If it's insulinoma, you go for C-peptide. If you go for glucagonoma, you could go for glucagon. Gastrinoma, you go for gastrin, so on and so forth. The localization of the tumor, as I mentioned earlier, for CT scan will be the best. MRI may help a bit. PET scan usually not so useful again in this because the tumor usually does not have a high metabolic rate because they are well defined tumor. US might help, especially to locate the small tumor. And there is also the octreotide scan because some of this tumor can secrete take up the octreotide. So the scintigraphy, this is like radionucleotide imaging. Okay, and serum chromogranin A has been used as well as a marker to detect presence of a neuroendocrine tumor and also to look for monitoring of surveillance. In terms of treatment, obviously surgical resection is needed. For size of tumor less than 2 centimeter, you can do enucleation. But anything bigger, you might need to consider pancreatectomy, Whipple, pancreatic, pylorus preserving, even distal pancreatectomy, depending on the location of the tumor. And as I mentioned, for gastrectomy, if say the location is near it's not in the pancreas itself, but maybe near the stomach. There's also a concept of what we call debulking or cytoreductive surgery, where studies have shown by removing most of the tumor as much as possible without doing too much it can also be good in terms of improving survival. And there are also targeted therapy available, but they're not as good as our chemotherapy lah. The thing about neuroendocrine tumor in general is that they have good prognosis because they're very slow growing tumor, very slow growing, and they hardly metastasize. So they don't cause any mass effect. If they're functioning, then only you have to do something to remove it, and usually the removal will mean that it's almost curative and they have a good quality of life. So prognosis, even with meds, less than 5 years, so you get 50%. It's higher. Like glucagonoma is 60% with meds. Non-functional 50%. So definitely much higher compared to other tumors. But there are some like lipoma, only 1/3 is cured after resection. Somatostatinoma rarely being cured. Okay, and for MEN1, it's associated with poor prognosis as well because this is not only one tumor we're talking about, we have other disease part of the syndrome. So they reduce the life expectancy by 10 years. So the take-home message is that adenocarcinoma is a very common cancer that is a very poor prognosis compared to other tumors at any stage. You compare with breast, with thyroid, with colon cancer. And usually present very late due to the very subtle signs and symptoms. So we have to be vigilant and sometimes over investigate, especially when patient having multiple visits to hospital for something that sounds trivial. So don't hesitate to suggest OGD and ultrasound early on when patient has this kind of history. Especially when you're working in the hospital, you must ask the patient, how many times have they seek treatment for the same condition or same symptoms but never resolve? And what more if patient now exhibiting symptoms suggestive malignancy like weight loss, steatoria. So you need to be a bit more proactive, especially when you are in the tertiary center, right? And the principles of oncology management, obviously the diagnosis, you need to obtain the diagnosis from the history and examination, along with the appropriate blood investigation and imaging. And staging as well. In terms of oncology, you must include staging. Sorry, I haven't put down the MDT. You might need to include MDT, multidisciplinary meeting, to decide on what is the best treatment modality for the patient. Next is nutrition. So nutrition is very important, especially when the patient is actually presenting with obstructive jaundice. So that means they are unable to digest fat. Therefore, they are deficient in vitamins A, D, E, K, which will then affect their coagulation profile. So you need to make sure that patient is well nourished. Basically, you need to start or oral nutrition support if possible, or even TPN sometimes. Because the patient is resectable, you need to optimize the patient as soon as possible so that you may proceed with surgery. Jaundice management, as we've discussed, may need ERCP, or even if patient not able to be cannulated using the ERCP, we can do PTBD. I didn't mention the PTBD earlier. We can do PTBD as well, as we have Prof. Razali and the radiology department for the interventional radiology. So we can do that. And the definitive treatment in terms of curative or palliative, depending on the staging and the diagnosis of the patient. All right. I think that is the end of the lecture. 1 hour. Okay, any questions?
Mr.
Yeah.
Question. You said just now we don't usually perform biopsy because if from imaging the tumor is resectable, we just resect the tumor directly.
Yeah.
But may I know when do we perform FNAC through ERCP? Because I have found a patient in HDA that is apa? The next step is to do FNAC and ERCP. So when do we decide? When to do
Okay.
it?
For for tumor that is resectable, okay, meaning that when you do the scan, it's already showing that it is resectable. We straight away plan for resection. We don't delay with FNAC or any biopsy at all. Okay, because the longer you wait, as I mentioned, patient normally tend to present at the later stage. They are already malnourished. They are jaundice. Okay, and with sometimes with comorbids and all and so forth. But more to the point, we do not want to delay further as to wait for the tumor to grow and cause more complications. So in pancreatic cancer, you do not need to wait for the HPE to come back because you can see already the tumor is there on the scan. It is now causing obstruction to the biliary system. So you don't need to wait. I mean, because you have to remove it anyway. Regardless, your HPE come back as benign or the HPE come back as malignant, you're going to have to remove it anyway. But if say you're saying, okay, this is a distal, how about if it's distal tumor? There is no obstruction, there is no symptom. Similar as well. If the tumor is resectable, do not need to wait further. Go and resect because you're not going to be able. Some more distal pancreatectomy is quite a safe procedure. It's not does not involve any anastomosis. So it's just basically resecting and making sure that you do not develop any pancreatic fistula. That's all. The one that you are a bit iffy is when you think this is non-resectable tumor. Therefore, I need to confirm the diagnosis before I can pass this patient over to the oncologist for them to start the chemo. Because, for example, we have two patients in SUSMEC. Despite our best effort, actually not just two lah, we have a few more before as well. We have done multiple times EUS. We have done even one or two patients during surgery, direct biopsy of the tumor. Didn't show us the tumor itself. Yet, few months down the line, patient developed metastasis to liver, metastasis to the lung, which means that it is definitely malignancy. But it's just that when we biopsy, somehow the tissue that we got was not representative. But we can't do anything. It is open biopsy. We touch it. That's the hard part. That's the tumor. We took it from there. It's negative. So in essence, the when the tumor is resectable in pancreatic cancer, I'm not talking other cancer, pancreatic cancer, tumor resectable, you resect straight away. If the tumor is not currently resectable, For example, you think the patient might require new adjuvant. That one, okay. You take biopsy. Okay, betul New adjuvant, take biopsy. If the tumor is non-resectable, then or for example, patient not fit for surgery, tumor resectable, tapi patient not fit for surgery. That means you know that sampai bila-bila pun patient ni will not undergo resection and you want to give chemo lah, definitive chemo or radio. Take biopsy. And the last is that if the tumor is already metastasized, confirm on scan that the tumor, for example, have metastasized to the liver, metastasized to the lung, you take biopsy. For the purpose to confirm diagnosis, you give to the oncologist, okay, this is confirmed pancreatic cancer, please give palliative chemo. Clear?
Clear, Mr. Thank you.
All right. Any other question? No?
Mr. I would like to confirm if the tumor is resectable but there is nodal involvement,
Okay.
does that count as
Okay.
resectable or not?
All right. So for nodal involvement, if it's local nodal involvement, meaning that the nodes are around the area that you're going to resect, no problem. That is resectable. But if the nodes already involve para-aortic elsewhere as well, distant nodal group, that we will have to discuss in multidisciplinary meeting. But normally even kalau ada para-aortic lah, tumor resectable, no solid organ tumor, patient fit for surgery, we go for resection. The nodes tu nanti kita bagi chemo. Because most of the time, tumor not resectable. Patient not fit for surgery, for example. Tapi kalau kata small lymph nodes elsewhere, para-aortic, para-caval, but the tumor is resectable, no evidence of metastasis elsewhere, patient fit for surgery, we would then discuss in MDT meeting for resection. And we discuss with the patient lah. That really. Boleh? Clear?
Okay, thank you, Mr.
Any other question? Clear on pancreatic cancer Alright. Tadi mengambil siswa apa? Tajuk apa?
Colorectal CA.
Nice. Alright. Okay. So gastric cancer, esophageal cancer tak ada?
Tak ada. Next series atau next series. Kita orang baru start slow-slow je.
Ada next series lagi lah. Ada orang lain
Ada,
ingat.
ada.
Oh, itu nak bagi apa? Prognasi, is it?
That one still on discussion lagi.
Oh, okay.
Sorry, Mr. I have one more short question.
Yeah.
I have read somewhere when the tumor is at the body or the tail of the pancreas, we will opt, if it's resectable, we will opt for distal pancreatectomy.
Betul.
But there are some that it said that we also need to do splenectomy. Is that something that we practice or no?
Okay. Dulu, before the refinement of surgical technique, even before laparoscopy, people would sacrifice the pancreas. Yes, you are right. But with the current practice, people try to preserve the pancreas as much as possible. So you can actually get away. The idea was like this. Kenapa kita buat macam tu? Because kita nak dissect around the splenic artery tu. Because why? We want to get the lymph nodes. Okay. So we try to get the lymph node without injuring the splenic artery so that we can actually clear everything. But nowadays, And many studies have shown that you can actually dissect the pancreas safely from the splenic artery, preserve the splenic artery, and do your lymph node dissection without detriment to the oncological outcome. Okay. Satu, kita nak preserve the spleen for the immunological, hematological function of the patient. Tapi at the same time, you must remember the aim of your surgery was to gain an oncological outcome as well. So if your oncological outcome tak dapat because you nak preserve the spleen, then there was no point doing the surgery in the first place. So memang kita akan ambil concern daripada patient, kata there is chance that we might injure the vessel and we may need to sacrifice the spleen, whereby you will have to be treated of a splenectomy patient. But on the outset of the surgery itself, kita tidak aim to go and resect the spleen from the beginning unless the tumor is very close to the spleen. Why we tell the patient this? Because sometimes on the CT scan you nampak macam spleen is preserved, but then when you go in, alamak, dah terkena semua benda, macam mana nak preserve? Especially when it's at the tail near the hilum. So you can't really preserve the spleen anymore. So you have to take it together. So yes, can be performed without taking out the spleen, depending on the location. But at the same time, sometimes we have to make sure that the oncological outcome is achievable. Clear?
Okay, thank you, Mr.
Alrighty. Okay then. Yeah. I have other things to look after. So okay. Anything else, you can contact me if you want to ask any more question. So we end our session with tasbih kafarah and surah Al-As. Subhanakallah.